Hi everybody, this is Lisa, and welcome to this module on sexuality and aging. Here are the objectives for this module. We're going to describe the impact aging and treatments associating with aging have on sexual function. We're going to compare and contrast models of addressing sexual function in older adults, and we're going to discuss sexual issues which affect non-conforming older adults, as well as institutionalized older adults and adults with chronic conditions and disabilities. Okay, so in terms of sexuality in general, exploring it, learning about ourselves in relationship to it really is a lifelong process, and it is influenced by many things, many things. Our background is one of them. Did we grow up in an atmosphere that discouraged talking about sex, for example, or one that was more open and permissive? How does our spirituality or religious beliefs affect our views of sex and sexuality? Are we comfortable in our bodies and with our gender identities? How does this add up to our present view of ourselves as sexual beings? So as we are going through the module and making some generalizations based on age, just remember that no group of people is a monolith, and we all have individual influences that we carry with us straight through to old age. Now, as a society, we are uncomfortable with the thought of older people engaging in sexual activity. Our ideal sexual embodiment, and what we base most of our romantic books and movies and notions on, is the young person with the beautiful face and body. However, sexual identity in older people is not extinguished just because of age. The feelings and urges may change, as well as the circumstances, but older adults can and do engage in sexual activity. Now, like other aspects of life, sex in older adults is affected by a lot of natural aging conditions and chronic conditions, but those are challenges that can often be overcome with some education and treatment. Sex is good for you. Your book reviews several studies throughout the chapter that seem to confirm that. Consensual sex has many conferred benefits, including better health overall, longer lifespans, closer relationships, and a way to escape tensions and day-to-day stress. Now, obviously, correlation does not equal causation, and it is, of course, entirely possible that people who start with better health and better relationships have better sex as older adults, but there definitely is a relationship between the two. So we know that older people continue to enjoy sex, but we also know that, like in other aspects of life, changes with aging does affect the way we experience sex. Sex hormones do affect the physical response to arousal and to sexual activity, but it does not change desire or willingness. For women whose bodies are designed not just for the act of sex, but for the childbirth that often results from it, menopause, the cessation of the menses that accompanies the drop in estrogen is probably the clearest evidence that we are getting older and the sexual part of ourselves is changing. Now, as menopause nears, a woman's ovaries make less of estrogen, and when this decrease occurs, the menstrual cycle obviously starts to change, becomes irregular, and then stops for most of us. Physical changes can also happen as your body adapts to the different levels of the hormone. The vaginal walls thin, for example. Many older women notice that their bodies don't respond as quickly to sexual arousal as they used to, and they don't have as strong orgasms. Of course, there are a lot of other physiological changes that happen as a result of the drop in estrogen, including the hot flashes and sweating we have all heard about or experienced. For some women, the onset of menopause is relatively easy and sex improves now that the possibility of pregnancy has been removed. Other women really struggle with it, not just the physical symptoms, but also because there is a sense of loss, as fertility is associated with youth and desirableness. Your book talks about estrogen replacement therapy, so I'll just mention it here. For women for whom the effects of menopause are very difficult to manage, estrogen replacement therapy can be an option, albeit a fraught one. It undoubtedly helps to ease the symptoms like hot flashes, but it comes at a price of increased risk of heart disease and stroke, gynecological cancers, and potentially cognitive decline. It isn't for everyone, and the decision to use it or not to use it is one where the risks must really be balanced with the benefits. Now, for men for whom childbearing is obviously not a factor, men can father children well into old age. The changes are less dramatic, and there isn't an absolute event that they can point to and say, this is where the changes began. Most effects are due to a drop in testosterone, and as a result, older men are likely to demonstrate some level of erectile dysfunction and changes in how they experience orgasm. And over the past couple of decades, the popularity of medication therapy for erectile dysfunction, like sildenafil, which is the generic name for Viagra, really shows that there are very many older men out there who are still anxious and eager to engage in sexual activity. Now, for us as healthcare professionals, we really need to be comfortable talking with our older patients about sex and not waiting for them to bring it up, because it is a sensitive subject for many. It's vital that we initiate and make ourselves fully available to have these types of conversations, and it really needs to become a normal part of an assessment or evaluation of an older person's functional capacity. Engaging them, asking open-ended questions, and allowing them to tell us their experiences without judgment on our part is crucial. Again, it's important for us to be sensitive and respectful, as this is a difficult subject for many older people to even broach, let alone discuss, especially if they have had poor or even traumatic experiences in their past. It's helpful if we are knowledgeable about the subject. We don't have to be experts, certainly, but we should know something about what the physiologic changes look like and what the potential intervention strategies are, and that we know what our referral sources are in case there's an issue that's presented that's outside our scope. The issue of safer sex is actually mentioned in the HIV section of your book, but I think it's just as important for any older adult, especially one not in a long-term monogamous relationship. Sexually transmitted diseases, including HIV, have been on the rise for quite some time now, and the game has changed for many older adults if they are new to or re-entering the dating market. It's important that they know they can still get an STD, and what are the safer sex practices like using a condom that can help prevent transmission. In terms of the models, your book goes through a couple of them. The PLISSIT model, which is also known as the model of sex therapy, is a system used in the healthcare field, to determine the different levels of intervention for individual clients. The model was created in 1976, so it's been around for a while. And the letters of the name refer to the 4 different levels of intervention that a healthcare professional can apply when working with a patient. First, there's permission, where the client is given permission to discuss any sexual concerns they may have, and have it received in a non-judgmental manner. Limited information, where specific facts related to the concern are provided. Specific suggestions or concrete strategies given to address the concern or behavior. Now, many healthcare providers feel comfortable engaging in these first levels of intervention, and the last, intensive therapy, is when a client is referred to long-term treatment by a licensed or specialized professional. The recognition model is a newer model proposed in 2010, and it stresses a team-based approach and take steps to ensure that each individual, regardless of age or disability, is seen as a sexual being. And that steps are taken to ensure engagement and communication between the patient and the team, that issues or concerns surrounding sex are addressed and explored, and that the individual is referred to the proper source to help them resolve their problem. The third approach here is something that we all can do, have been doing for a long time, which is to explore with patients certain areas of concern regarding their sexual function. Older adults often have esteem issues regarding their aging bodies, comparing the body they have now to the body they had when they were younger, the performances that they're capable of now compared to when they were younger. And practitioners really do, healthcare professionals really do need to make ourselves available to have these discussions in an open and accepting manner. As far as sexual functioning and health problems go, there are many, many, many chronic conditions and illnesses that can affect sexual function in the older adult. Your book lists common ones that affect issues such as mobility, endurance, pain, fatigue. It's a long list. I won't bore you by reciting the diseases and the suggestions for overcoming the issues or modifying the practices to compensate it. It's collected on table 13.3 in your book. I will say I am surprised that diabetes is not listed as a cause of sexual dysfunction, as one of its most common effects is erectile dysfunction in men and reduced sensation in women. Now, regular sex can actually be a treatment of sorts for some conditions, given that the hormones and endorphins released are known to decrease discomfort and heighten a sense of well-being. Medication effects on sexual function are legion, and your book in table 13.4 lists just a few. It's vitally important that any potential effects on sexual functions be discussed with patients beforehand, as non-adherence to medication therapy is often the result of a patient being displeased with the effects of the medication on their sex life. Very often the medication regime can be changed or other steps taken to eliminate the problem. Psychiatric medications and antihypertensives, which are two very widely prescribed classes of meds, are some of the worst offenders in this regard. Inappropriate sexual behaviors towards practitioners does happen. It can range from somebody flattering you, saying, oh, you look really nice and beautiful in that dress, to actually inappropriate sexual fondling, touching, those types of things. Obviously, it interferes with care and intervention services. Most of us in the business have had it happen at one time or another. And there are a number of options that people have, practitioners have, to handle it. Your book says one thing is to ignore the inappropriate sexual behavior, which is certainly an option. It does kind of create a little bit of a rift between the professional and the person doing the behavior, and it doesn't really allow for a lot of communication and non-judgmental approach to happen. It's entirely within our right to refuse to accept behavior from a client, an older client, that you wouldn't take from anybody else, depending on the conversation you have with the client, the relationship. It's important to immediately report repeated behavior to let people know that this is likely to occur, this has occurred, and then to develop a kind of a behavioral plan around it. When this person says this, this is the response everybody is inclined to get. My own experience with it has often been that there's some cognitive impairment that's involved, that older people who have always related to somebody of a different sex, or even somebody of the same sex in a certain way and seen them in a certain way, carries that with them as they get a little bit older. Be aware of it, understand that you will probably face it in your practice. We are involved with people on very intimate levels, and sometimes this does happen. Uh, we'll move on into what your book calls special populations, and we'll start with older lesbians and gay males. They are a very diverse group. Obviously, they have a lot of the same age-related issues that the heterosexual population does. Testosterone and estrogen drops, chronic diseases, stress about body image, and those types of things. Also layered on top of that is the growing up that occurred in this generation, constructing meaning around their sexual identity while living in a heterosexually dominated society. These people came of sexual age before even the advent of civil unions, even much less marriage. And they have had to declare their sexuality many times over, which is something that people in heterosexual relationships have not had to do. Often practitioners are uncomfortable talking about sex that is not between two straight people, and they may ignore them or kind of turf them off. This can make people feel very marginalized or fear discrimination, and that is with some justification. So it really is important that we are able to have the same conversations with people across the sexual spectrum as we do with people who are heterosexual in their approach. Some of the recommendations they have, again, this looks a lot like the general message we give about discussing sex in the older population, regardless of sexual orientation. We want to understand that for older lesbians, older gay males, sex remains important in their lives, that they may need a variety of sexual behaviors outside the scope of something that a heterosexual practitioner may be familiar with. And again, we always need to maintain an open and non-judgmental view of sexual activity in late life and be willing to learn and take direction from some of our patients whose experiences are different than ours. Now, although the spotlight on transgender individuals has increased in the last 5 or 10 years, transgender adults have always been with us, and they certainly do exist in the older adult population. Transgender is an umbrella term whose gender identity, whose expression of themselves as a sexual person or behavior doesn't conform to that which we typically think of as associated with the sex to which somebody was assigned at birth. And the opposite term of that is cisgender, which is a person who identifies with the gender they were assigned at birth. Gender nonconforming people really have continued to face challenges, blending into society, obtaining quality of life. There really has difficulty in finding practitioners who are fluent in the care and concern of transgender adults, and even fewer who are familiar with transgender older adults. This can often make the older transgender individual feel marginalized. They often are very hesitant to seek medical assistance because they fear judgment. They fear finding somebody who doesn't understand them and won't commit to helping them solve their issues. And this obviously can negatively impact health and stress level. Again, as healthcare practitioners, I don't think we can say this too often. We need to be sensitive. We need to be supportive. We need to provide a culturally safe service that people can feel like they can be themselves without fear of judgment. We need to ensure that families of choice, and this is true, I mean, it's here under the transgender section, because transgender adults often, I won't say often, but are estranged from families of origin. So we want to make sure that families of choice are included in treatment and care. And we also want to be very straightforward in asking people how they wish to be addressed. For older adults with disabilities, sex and disability tends to be a taboo area for many persons, even more so probably than older adults in general. It's rarely a topic of discussion or research. And as a result, studies indicate that more than 50% of disabled people report not having any form of a regular sex life. And if the disability happened later on in life, the person may compare themselves now to who they were prior to the disability, how they used to look, how they used to feel, and feel very unattractive by comparison to who they once were. Obviously, long-standing physical disabilities, such as things like multiple sclerosis, which comes on relatively early in life, or cerebral palsy, can be worsened by the normal effects of aging. And the physical and emotional aspects of sexuality, despite the physical loss of function, continue to be just as important for disabled people as for non-disabled people. For couples for whom one partner has a disability and the other doesn't, there's reported declines in frequency and changes in approach and decrease in interest. And things like fear, discomfort, stress contribute to these physical limitations. Education and the promotion of adaptive coping strategies can play a big role in mitigating some of these issues. I'm going to spend a little extra time on the topic of older adults living in nursing facilities, because this often involves a group of stakeholders and policy decisions rather than just a consultation with one particular person or couple. The need for intimacy and sexual expression does not disappear as an older person becomes reliant on others for care. And healthcare providers in these settings should acknowledge these needs and rights in order to provide person-centered care. I remember when I first started in nursing education, this was like 2003, so it's been close to 20 years. I had a young student. We were in a nursing home. They were having their first clinical experience in a nursing home. And I had a young student who was, we had a physical assessment and checklist that we would have them go through. And one of my young students was absolutely mortified that she was going to have to ask this older man who was probably, mid to late 70s, wheelchair bound, so disabled and elderly, ask him about sexual concerns. She couldn't understand why she had to ask that, why that was important, but she sucked it up and she did it, and she got a torrent from this man about how the facility was not providing him a place for him to be intimate with his wife. She really was shocked. It was a real learning moment for her. And it really brought to fore how important these issues are to people across the age and ability spectrum. There are things that institutions can do. Many of them set aside a room where couples may want to spend time alone to pursue some intimate relationships, help coordinate some private time for residents who have a roommate that is not their partner. Obviously, there's a lot of coordination that goes around that, as long as some discomfort perhaps both on the part of the person who is doing the asking and on the part of the person who is doing the coordination. But for our healthcare practitioners, and we are talking a lot of people who take care of a lot of people in these facilities, from nurses' aides, nurses, other professionals, We really need to be aware of myths and realities surrounding sex and sexuality in later life. For a lot of the younger staff that come to work in these places, this is the first real interaction they may have had with older people. And like any of the rest of us socialized in the United States, they have myths and biases about the elderly adult population and sex. You want to make sure that the people are educated about what these needs are, and you want to make sure that residents are shielded from abuse in these facilities. They're very often somebody may be in a facility that has a non-institutionalized partner, so that partner needs to be considered as really part of the patient in receiving support and education. And again, we need to be aware of our own prejudices and biases. If we think that it's really disgusting that two older people are engaging in sex behind a closed door while people are passing medications outside, we're not going to be very helpful in what it is and how we approach this. Consent is kind of a point of contention in regards to persons who are institutionalized. And it really is crucial to ensure that an older adult is not being taken sexual advantage of by a partner. And because what happens on occasion is that an older partner is in a nursing home because of cognitive issues, for example. And they may have a non-institutionalized partner who does not have these issues, who is used to having an active sex life with this person, and now wants to continue that, but the person to whom they are married really no longer has the ability to give consent. That can become kind of a sticky issue. And so a lot of time and effort and education often needs to go in along that. By and large, though, somebody who is alert, oriented, their own guardian, signing their own paperwork, making their own decisions, is assumed to be competent until proven otherwise, for example. Now, again, this is an issue for our facilities as well as for the people who are living in there. So some of the recommendations they talk are to make sure that to assemble the stakeholders, the partners, the residents, the staff, understand what the issues are. Is it that there is no place for them to go, that there is no privacy in the places that are established, or that the people who are tasked with making this happen are giving them attitude? What are some sample policies that we can make up? What are some interventions that we are going to put in place for everybody? And then to finally sit and make sure that there's a policy in place for people to follow when these things happen, and they will. Okay, so I'm just going to leave you with the thought that recognizing the importance of sexuality and sexual activity as vital aspects in the lives of older adults really is very beneficial for people. It can help our older adult clients maintain or enhance their self-esteem, as well as increase their options for intimacy and promote a real sense of well-being. That is the end of this module. Thank you for your attention.